And we're recording. So good afternoon, everyone, and welcome back to our launch of our new community health profiles, where we're delivering a series of 11 webinars on intro to health inequalities in a series of communities directly related to our new community health profile launch. We will also at some point today be asking everyone to fill out a feedback form that should be put in the chat. If you could please fill that out at the end of the session, that would be really appreciated. It should only take about 5 minutes. But just to make sure that the sessions kind of run as smoothly as possible going forward. So the agenda for today, we've got a couple of points to cover. So we'll start off with just a couple of introductions, getting accustomed to what we're going to be talking about today. We're also going to be using Mentimeter, so we'll get everyone set up on that online and make sure that we're familiar with how to use the software for those that haven't used it before. Then we're going to quickly look at a community overview, so including some of the demographic data, so a bit about the geography and the other demographics like age and religion, ethnicity, etc. We're also going to be covering a little bit about the data and how we identify populations to be included in what we're going to be talking about today for the health inequalities. I'll then spend about 20 minutes going over some key health inequalities that align with the sections in the report that link directly to the health and wellbeing strategy. And it's just important that I'd like to highlight at this point that we only have an hour today, so I'm not going to be able to give a complete and comprehensive overview of health inequalities. So please just use this as like a start point to develop learning further. Then going to cover how we're going to incorporate these health inequality findings into our work and what we can take away from the session. And then I'll quickly cover some upcoming opportunities that we have to be involved more in this work if it's something that's interesting to you, and some potential upcoming funding opportunities that we have as well. So just some quick housekeeping, pretty standard procedure for anyone that's come to a Teams webinar before, but just please keep yourself muted and turn off any VPNs you have throughout the webinar, just to help things run a little bit more smoothly, save a bit of bandwidth. You are welcome to unmute yourself and ask any questions if you want to at any point, but we will have like a designated Q&A section at the end. We will also have a chat function to ask any questions. But say if you want to have ask anonymized questions, it's something you're not comfortable asking, there will be an option on the Mentimeter to ask an anonymous Q&A on text only, so you don't have to verbalise it if you're not comfortable with that. The slides will be uploaded to the Birmingham City Council website shortly after this webinar under the Community Health Profiles homepage, and a recording will be uploaded to the Healthy Bum YouTube channel. But anyone that's signed up to this webinar on Eventbrite will be sent both the recording link and the PowerPoint slides, hopefully within the next 24 hours or so after this webinar. So just a quick overview onto our community health profiles. I'm not going to spend too much time talking about these because we do have other resources available, but just for those that are unfamiliar with them, we at Public Health have created a key set of resources that look at summarising the physical health, mental health, lifestyle, behaviour and other wider determinants of health related to issues in like a specific community. And we use these as a way of going away from homogenising communities by using terms such as BAME or LGBTQ+, which often overlook huge differences in health outcomes between specific population groups. So today we'll look at, for example, our specific gay men and other men who have sex with men profile. We also have available a bisexual profile, a lesbian profile and a trans profile to really kind of show out those separate and unique health inequalities that are experienced across the different community groups. There is a full report available on the website, and again, you'll have the link to be able to review this. There is quite a lengthy document of about 90 pages long. So we've also created an infographic summary, which is just a one-page short snapshot of all of the inequalities in the different sections. If you're interested in this line of work and how it was produced, what the methodology behind it is and what data we included, we have created a short intro to community health profile videos. So we don't have to, if you're interested in more information, you can go watch that. So we don't have to spend a lot of the time in the webinar today talking about research methodology. Okay, so we're going to get everyone set up on Menti for a few seconds. So if you've not used Menti before, it's an interactive quiz software technology that we can use just to make these webinars a little bit more engaging. So it's not just me speaking at you for an hour long, because I know that that's not ideal for anyone. So if you want to join on to the Menti, you can either use your phone or any other kind of portable device and scan the QR code, or you can go to menti.com and enter in the code 1627279, or you can go to the link in the chat that Joe has put there. Now, the Menti joining instructions should be at the top of the other Menti slides as well. So don't worry if you can't immediately get access, but use the one in the chat if you need to refer back to it. But just to get us started with some Menti, while everyone's kind of getting accustomed to using it, we're going to just start with something nice and easy to get people used to the technology. And we're just going to look at, is there anything that you're looking forward particularly to learning or discussing in today's webinar? If there's a couple of key points that come out that people are interested in, I can potentially put a little bit more focus on a particular topic area or discussion point. And if you don't know what your answer is at this point, and it is just, I'm here for curiosity, that's more than fine. Pop that in there as well. So most people, by the looks of it, are in here just for some learning, wanting to know more about the community and those barriers to healthcare. Yes, so I will definitely be covering both of those today and the health inequalities. Now, I'm not going to spend too long on this intro one. It's just to kind of make sure that people understand how to use Menti. Areas need to improve. I'm interested to know more. Health issues. Perfect. Right. Thanks, everyone. So moving on, going to have almost like a little quiz session, just something a little bit fun, not about health inequalities to start with. Again, just to get accustomed to using Menti. And we're going to be talking about a little bit about LGBT history and just wanted to see kind of what people's knowledge in the room is. So we're going to be talking about pride marches. I don't want to give away what the question is. And it's just to see kind of what people's current community knowledge is. I've not used this feature before, so we'll see if it how it goes down. Get a couple of people kind of ready to go. And then if you want to start the quiz in a second, Alex. So we're just looking at when was the first Pride March in the UK? Now, it's a quick one. I think you only have 20 seconds to answer. So we'll see if anyone has been able to do that. Don't think we've done it quick enough. If anyone knows and wants to pop it in the chat, we won't use this feature again. But does anyone know when it was? The options were 1970, 1972, 1974, or 1976. We'll make a note for next time to give people more time to answer that question. No, sorry, we'll move on then. The answer was 1972. We just wanted to kind of test out a new Menti function, but no, take it. Oh, no, it did work. There we go. Sorry. So someone got it right. We got a 1972. So one person is very clued up on their LGBT history, but the answers were quite tricky because they were all very close to one another. So deliberately made it tricky, but thanks, Alex. I didn't realise that it had worked. That's reassuring. So let's move on to actually some of the intro into the community. So first, before I'm going to talk about some of the demographics, talk about some of the different language that's going to be included either in the profile or in the webinar today, in case you've kind of not come across any of the terms before. Now, you'll notice that this webinar and the title of the report is Gay Men and Other Men Who Have Sex with Men, not just gay men. And if no one's familiar with that term, what MSN or Men Who Have Sex with Men refers to is just in a clinical setting refers to sexual behaviour only, regardless of sexual orientation. And it can comprise a diverse group of people in terms of behaviours, identities and healthcare needs. Quite often, gay men and other men who have sex with men are grouped into the same category when we talk about things like sexual health. And a lot of the findings throughout this report didn't differentiate between gay men and other men who have sex with men. And the data often doesn't kind of provide those specific health needs. But in terms of things like sexual health, there are going to be similar health needs, and that's why it's presented in that way. Men who have sex with men could define people that identify as LGBTQ+, but are not included in what's normally the full phrase of gay, bisexual, and other men who have sex with men. So it may incorporate people who have identities like pansexual, but it may also include non-LGBTQ+ men that have sex with men, so people that do identify as heterosexual. And this could be for a multitude of reasons. It could be a potential fear or a barrier to coming out due to stigma, that they don't kind of feel comfortable with that identity yet. But there is also a category of men that have little to no same-sex attraction, but still have sex with other men. So this might be people that are sex workers or swingers with female partners, but actually might have similar health needs to those other men who have sex with men. When we look at coming out, it's just about the first time someone tells you about their orientation. And it's important that if you're having these conversations with service users about coming out and about their identity, to be a bit sensitive and understand that an LGBT person doesn't come out once, but actually comes out in every new situation. So it can be quite a repetitive conversation with them. So just to approach that with a little bit of sensitivity. Homophobia, I think that's probably one term that most people have come across before, and is generally talking about the dislike or prejudice of someone based on their LGBT identity. And lastly, we have the term heteronormativity, which is the assumption that somebody is straight or heterosexual as the default option. This often erases different LGBTQ plus identities and can overlook those specific health inequalities if that identity has not been gathered in data. It's a suggestion might be to use gender neutral language when possible and avoid any assumptions of behaviour based on identity or based on current relationship status. So again, like in medical settings, gay men may be incorrectly categorised as heterosexual due to a service provider's bias and assumptions, which may lead to not being given the most relevant and specific health advice. When we look at the data collection that we use to analyse people that identify as gay, there is some limitations to note. So next slide, please. Thank you, Alex. So in the 2021 census, it was great because there was 2 new questions on sexual orientation and gender identity that haven't been included before, with the aim of further understanding our LGBTQ plus populations in Birmingham and in England and Wales. These were optional questions, unlike most in the census, and they were only asked to participants that are aged 16 or over. The main limitation when we talk about gay men is that the data is still unclear in the census because the grouping of categories, gay or lesbian, was one category, and it was really difficult to do additional analysis. We could do a little bit about sexual orientation by gender to break that down that way, but in terms of that multivariate analysis from the census to understand specific education outcomes, general health, physical health, qualification, housing, all of those other wider terms of health couldn't really be specifically identified from the census as it grouped gay and lesbian populations together. Similarly, as I mentioned before, gay men are often in data presented with other men who have sex with men. So those are just some considerations to understand that actually getting community-specific data on a specific LGBT population is quite difficult in some of these situations. There are some other considerations that you should have when collecting data, and specifically when you're looking at LGBTQ plus and gay communities, is some of the other things I've listed on screen here that may be the most appropriate questions to ask in different service settings. So for example, it may be more appropriate to ask about current sexual behaviour rather than identity and orientation when you're in a setting looking at sexual health. As I was saying before, if some men who have sex with men may not identify as gay or bisexual, but still have those health needs. And again, in other contexts, understanding a person's orientation may be more important than their current behaviours. So understanding how social factors relating to sexual orientation, like discrimination experienced by gay men, and how that can impact on health behaviours and inequalities, like how that can impact on mental health, negative experiences in different healthcare settings. So it's understanding which questions are most appropriate for what you're actually trying to understand. And in some health contexts, it's also important to understand the intersections with gender identity. So, for example, a trans man who identifies as gay may have different health needs to a cis man, a cis gay man. So, for example, the need maybe for still undertaking cervical cancer screenings. So it's really understanding what the most appropriate questions are in data. There are some other limitations to this data before we kind of move on to the demographics. As I said before, the census groups gay and lesbian together, so there's that significant limited understanding there. Often in a lot of data sets, specifically, it's grouped together with just wider LGB or LGBTQ plus cohorts, so the data isn't presented on those specific communities. And in a lot of those national data sets, like the GP patient survey and the health survey for England, often the data's not been adjusted, so it doesn't account for some of the demographic factors that we're going to be talking about in just a second. So we'll actually get into some of the information about demographics and geography now before going into an overview about the health inequalities. So when we look at population size, and next slide, please, Alex. Thank you. When we look at population size in Birmingham, around about 1% of the population identifies as gay or lesbian, and this accounts for 7,711, and this we were actually able to break down by gender. So this is specifically men that ticked that box, identify as gay or lesbian. As I previously mentioned, population size is likely going to be underestimated for all LGBTQ plus identities because of a lot of different barriers to population identification. So responses may be biased towards what they perceive as a socially acceptable answer. There may be non-disclosure on things like the census due to stigma or the perceived confidentiality of the data and how it's going to be used, and fear of being outed by different data sets. When we look at ethnic group, it is roughly similar to the England average. So 72% of gay men in the GP patient survey identified as white British compared to 74% of heterosexual men. Religion was a bit different compared to the general population. So 63% of gay men identified as having no religion, again in the GP patient survey, and this compares to only 39% of heterosexual men. And the age population is typically a bit younger, so 33%, around about a third of gay men in England and Wales, in Birmingham, were aged 16 to 24 compared to only 13% of heterosexual men. Now, it is useful to consider if this demographic data is reflective of populations that you engage with in healthcare settings or community health interventions. But it's also important to note that the demographics might not 100% be reflective of the community. So age demographics are likely to reflect a cohort that has increased safety to disclose and to self-identify compared to potentially older gay men. And just overall, there's more research going to be needed to clarify whether the difference in sexual orientation among different demographics like age and religion is different amongst different demographics, or if there is an underreporting of the identity based on barriers to coming out. Now that we know a little bit about who our population is, we can talk a bit about where they are in Birmingham. So the census mapping tool is really useful here as it helps us go down to specific community level and look at population distribution across the city. So those, again, we couldn't do the identification of gay or lesbian men in this case. We weren't able to disaggregate that by gender in this instance, but the population density ranges from around about 0.1% of the population to about 6% of the population. And so when you consider that the gay population makes up 1% of Birmingham, you can see how this population density varies depending on geography. So we can get down to MSOA level here, which is middle super output area, for those not familiar with that acronym, which is an area that contains around about 2,000 to 6,000 people, gets us a little bit more information than looking at ward levels overall. So for example, if we click through, you can zoom in on specific MSOAs and look at the population density, for example, of the central MSOA. So if you can flick along a little bit, Alex, please, to zoom in on that.
I think there's a bit of a lag when I'm clicking, by the way. I think that's why it's like slightly delayed.
Oh, okay, no worries. So why is it useful to know this information? So knowing the geography of a particular population may be really useful to help develop place-based community events or health interventions. But it's also important to note that the places where people live might not necessarily be always where the community engages. So it's important to use that mixture of the data and the community intelligence when looking at planning health interventions. So when we're talking about the gay and lesbian population, predominantly living in the centre of the city, looking at the central MSOA, Digbeth and Ladywood. So we've gone through a little bit of the demographic overviews. So I'm going to kind of talk through key health inequalities of the different areas of the gay community health profile. There should be another Menti question, but I'm sorry for the kind of delays in the slides, but we will have another Menti question now where we're going to look at confidence in how you feel about identifying specific health inequalities of the gay men population compared to other sexual orientation groups. So how confident does the average kind of participant feel about this? And hopefully we'll see how that changes after going through some of the different data. So it looks like we're around about smack bang in the middle. So people are somewhat confident, but could do with some more information. I think that is kind of what we've expected here. So we're also going to ask in the next slide, is how do you currently use health data to influence your decision making? Now, if you're not overly confident in this and you were someone that was closer to that 1 or 2 out of 5, it may be that you currently don't do this at all, and that's absolutely fine. This session can be a start point to moving towards that area. But it's just any way that anyone that does already use the data, how they currently use it. And this might help provide some ideas for people that don't currently use this in their work or in their organisation in what they could do going forward. I don't know if it's just a lag with the Menti again. So I will move on, and hopefully if you click along, Alex, it'll catch up if we're kind of a bit lagged on this one today.
Yeah, I'm not seeing any responses yet. I don't think there is any.
Okay, no worries then. So we'll move on to the health inequalities topics then. So it's important to mention before we move on that we might be talking about some triggering content or some triggering information. So just take that into mind when listening to the webinar. If that's something that kind of is not in your kind of remit, then feel free to leave. It's we understand that some of these are quite tricky conversations to have. So if that's something that is too much, absolutely understand that. We also want to take a couple of things into consideration when you listen to the data in the next following slides. So if you're someone that's joining from an organisation who works closely with gay men and community members, I want you, or if you are a community member yourself, I want you to think, does this data accurately reflect my previous experiences? Does this seem to mirror what I've seen in real life? And for people that are using this webinar as a way to learn about a community that you don't necessarily have much information on, does any of the data surprise you? Think about, does any of the data align with any of your previous knowledge? And we can use that to kind of formulate a little bit of a discussion at the end of the session. I'm also only going to be talking through one key data point or key source of information per slide. There is more in the profile, but as I said, I don't want to overwhelm with too much information in a short webinar. So we're just going to be covering one topic per slide. So first and foremost, we're going to start off with mental wellness and balance. Now, I have actually skipped over the Getting the Best Starting Life section. As I said before, the data on sexual orientation for young people is extremely limited, as most sources only take data from age 16 plus. So almost all of the data that we have on young people is just LGBTQ plus as a broad community, and there's very little that's talked specifically about the experiences of gay men. So we'll start with mental wellness and balance, and we'll be drawing some of the data from the Stonewall LGBTQ in Britain health report from 2018, and it's talking about mental health and wellbeing. Now, this is something that was reflected in all of the 4 LGBT profiles that we've written so far, is the experience of poor mental health is something that's quite prevalent. What we've actually seen among gay men is there's a higher experience of gay, bisexual and trans men who experience depression compared to men in the general population. And anxiety as well. Oh, slides have gone. Is Alex still in the webinar, Joe? Can you see? No, he's dropped off.
No, I can't see him in there.
Do you have the slides up and could you potentially share them?
Yeah, I can get the slides up now.
Yeah, thank you. Sorry about that delay, everyone. It seems to not want to run as smoothly as it did last week. I'll just briefly touch on the comment in the chat before we kind of get the slides back up. That yes, in the case of Stonewall, the data is a bit older. We've just picked this out because it's a large report. In the full profile, there are other journal articles, scientific research, other kind of national surveys that have been used as well. So it's not just that, but the figures themselves, the actual numbers may have changed slightly, but the overall picture of poor mental health and those associated risk factors have generally stayed consistent regardless of what report we've looked at. So I think Alex is back and I can see the slides back up. So sorry for that little blip there, but we'll get back
Sorry,
on again.
I think my Wi-Fi is playing up. It literally just cut out and cut me out of the call. Can you see it all right?
Yeah,
we can see it. I've got them open
sorry.
now, Jordan. So if you need them again, if Alex drops off, then let me know. I can get them up straight away. Sorry about that.
Perfect, thank you. So the main kind of findings that we want to draw on from these reports is, despite having high prevalence of different mental health experiences, is that actually less gay men accessed or tried to access services compared to other LGBTQ plus respondents. So it's really important to understand those qualitative research as to why. We couldn't quite find those barriers as to why it's harder to access services, but there are some risk factors in general associated with poor mental health, specifically in gay men. We have kind of grouped them into 3 different main categories. So there are those lifestyle and wider determinants that contribute to mental health. So this includes increased prevalence of substance misuse and more likely to have a lower income. There are different demographics, so those that are disabled, those that are single, those that have born abroad and migrated into the country are more likely to have poor mental health. And it's important to consider those intersectional factors, that being gay can be attributed to poor mental health risk factors, but being disabled can also contribute to poor mental health risk factors. So having those compounding inequalities and considering how different people with different intersectional identities are going to have compounding inequalities, especially when it comes to mental health. We also have a big topic about just homophobia in general, whether it's homophobic discrimination and bullying. Not being out is a risk factor for poor mental health, so those that are still not comfortable with their identity. There's internalized homophobia, experiences of, say, homophobic discrimination in the workplace or in schools, all identified as poor risk factors. When we talk about healthy and affordable food, there is not too much data on specific sexual orientations, and some of the evidence is mixed. So in the health survey for England, we looked for 2011 to 2018, gay men were frequently identified or were less frequently identified as being overweight compared with heterosexual men. But actually on the other end, there's conflicting information on prevalence of underweight. So in the health survey for England, they're suggesting there's no difference between gay men and heterosexual men in being underweight, but a couple of scientific journal articles that are listed in the reference list here show that there may actually be some differences in dietary patterns between gay men and heterosexual men. So, for example, there's some research that suggests higher risk factor for disordered eating behaviours such as binge eating, purging, and dietary weight restraint. A review article found actually that gay men were more likely to be underweight compared to heterosexual men, but as I said, the results are kind of conflicting in that area. And there's also some journal articles that talk about the differences in experiences with diet and diet culture. And one of the theorized differences that might be unique to gay men is the pressure to fit into a particular ideal of male body standards specific to the gay community. When we look at active lives, so we're looking at physical activity, the main source of information that we can get physical activity rates from are the Active Lives survey, but actually the National LGBT Partnership Report provided some useful qualitative insights here. So when we're talking about those that are being physically active, what this means is it's those that complete 150 minutes or more of moderate physical activity per week, and that's anything that raises the heart rate, such as brisk walking or cycling. But it can also be measured by those that complete 75 minutes or more of vigorous physical activity. So that's really high intensity exercise, such as running. And it was actually found that 67% of gay men reported being physically active, which was slightly higher than heterosexual men at 64%. So although there are the national data sets that talk about higher rates of physical activity, those smaller and LGBTQ plus specific studies typically report lower levels of physical activity. So again, in this national LGBT partnership report, 55% of gay men were categorised as not being active enough to maintain good health, and only 18% met their recommended guidelines compared to the 67% reported in the Active Lives surveys. Now, this may be down to differences in observed data sets from national compared to local based on whether it was self-reported or whether they were actually monitored with their physical activity throughout the study. Again, some may feel more comfortable reporting inactivity to LGBT specific studies. There are many kind of different reasons why the information might differ. But there were still some really interesting findings around about gay men's experiences of physical activity. And it was that lack of the main finding was the lack of supportive community in team sports. So the Active Life survey found that only 6% of gay men participate in team sports, compared to 17% of heterosexual men. And a different LGBT study out on the fields actually found that 70% of gay men found that homophobia was more common in team sport environments compared to general society. So one of those key barriers to good physical activity and the wellbeing associated with that is the ability to participate in a shared community that is supportive. When we look at living, working and learning well, one of the key things that comes out, unsurprisingly, is experiences of discrimination and homophobia. So when we look at coming out, gay men did actually feel more comfortable coming out as LGBT in the UK compared to other LGBT identities, but that still only sits at 2/3. So still a third of gay men feel uncomfortable and not supported to come out as gay in the UK. And that is often as a result of discrimination and other compounding factors. So it was found that almost a fifth of gay men have experienced homophobic instances in the workplace. Almost 20% have experienced a lack of understanding and appropriate care from a healthcare provider, and 10% even reported unequal treatment from that bias from healthcare services. So one of the key barriers that we're going to have when we're talking about access to healthcare services is having that appropriate care, whether it's appropriate language or advice and support and guidance, which is relevant and appropriate to the community, and factors like that. As I was talking about before, there is also the underlying theme of intersectionality throughout all of these reports. So when we look at those who are disabled or belonging to a global majority ethnic group that are also LGBTQ+, they typically have worse experiences of healthcare compared to non-disabled people and white LGBTQ+ people. And that's often just because of those compounding inequalities. If you're identifying as a gay man and you have that homophobia experiences and that unequal treatment from healthcare staff, but you're also from a community that doesn't speak English very well, you're going to have barriers to language and maybe not feel supported in that way. So there's going to be that compounding inequalities for those other identities alongside being gay. If we take a look at Protect and Detect, one of the key sources that we used in this part of the report was looking at sexual health and drawing on UKHSA data, which look at the rate of new STI diagnosis. And this is typically the area of the report which groups together gay men and other men who have sex with men. So in England, gay men have been identified as being at higher risk from STIs. So if we look at the prevalence rates, we've got 7,014 per 100,000 new STI diagnoses among bisexual, gay and other men who have sex with men, compared to only 291 per 100,000 in men who exclusively have sex with women. This was broken down by specific STIs, so you can look at the higher prevalence rates of specifically chlamydia, gonorrhea, herpes, syphilis, and genital warts, which was all identified as being higher diagnosis in bisexual, gay, and other men who have sex with men compared to men who exclusively have sex with women. There were some risk factors for sexual health that were identified. So, for example, the practice of chemsex being identified in gay, bisexual and other men who have sex with men communities. For those that have not seen it yet, there was a really good couple of webinars on chemsex topic as part of our LGBTQ+ month conference in February, which the video should be going up on our YouTube channel soon. So if you're interested in what chemsex is and how that contributes to potential risk factor for STIs, I would highly recommend you go and watch those webinars. Also, one of the other key barriers that we look at in terms of HIV is the use of PrEP, so pre-exposure prophylaxis. I can't say that very well, but as a drug that can be taken daily or is needed to prevent HIV being transmitted on. In a 2019 London-based study, we looked that in a sample of gay men that had need for PrEP, only 68% of them didn't currently report use of that. So that's kind of a key barrier that could help prevent STIs, is looking at how we can do that preventative healthcare aspect more and making sure that safe practice is used when needed. Finally, we're going to be talking about aging and dying well, so that end of life approach to health and well-being. Again, there was really limited data specifically on older gay men, and it was more generally targeted just towards older LGBTQ+ adults. Again, in terms of the age demographics, only 19% of gay men in England and Wales that are identified as gay men in the census were aged over 55 or over. So whether or not that's due to there being a smaller population group or whether it's those barriers to coming out, especially among older adults, as we talked about in that first slide. But there is a general consensus from the data that older LGBTQ plus people tend to experience poorer health and access to healthcare than heterosexual older adults. And there are additional barriers to accessing that end-of-life care. And some of the barriers I've lifted on screen here. So there's that delay in health-seeking behaviour due to fear of discrimination based on previous experiences, especially in the older gay community where it was highly criminalised when they were younger. That could really contribute to that delay in health-seeking behaviours in older life. There's that also in terms of discrimination, older LGBT adults may hide their identity from healthcare workers for that fear of discrimination. So again, may not be provided with the most appropriate support and signposted into relevant organisations that can support in end of life and older adult care if they're not comfortable with identifying their orientation to healthcare workers. Often the support groups that are available for older adults, so for example, in the report we talk about dementia groups, often are very heteronormative and don't necessarily provide culturally relevant support. So it may make older gay men feel excluded and not participate in the different support groups available. And also in a lot of cases, there is an inability to list a family of choice or a partner for end-of-life decision-making, which can make it really difficult to make sure that the person's end-of-life needs and wishes are honoured. So there is a lot of different inequalities. I know that we've kind of speed ran through. There is obviously going to be other health inequalities. It's really important, as I said, to not use this as a comprehensive understanding and apply this as the only health inequalities that gay men are going to experience. There's going to be other key inequality data, and it's also important to take a person-specific approach to health and wellbeing and understanding that someone's identity isn't the only factor that's going to contribute towards the health and wellbeing needs, and each individual person is going to have specific health and wellbeing needs. There are some of the other key inequalities that I should have highlighted on the next slide that have been identified throughout the report. If you would like more information on any of those, and they can be in the full report. So for example, there is a higher prevalence of hazardous drinking, illicit drug use and smoking that are identified in the Health Survey for England and the Crime Survey for England and the England Smoking Toolkit series. There's also information on neurodivergence. So in the Health Survey for England, gay and bisexual men reported higher rates of mental, behavioural and neurodevelopment disorders at 14% compared to 5% of heterosexual men. There's the experience of loneliness. In 2022, gay and lesbian people were identified as being 2.6 times more likely to experience chronic loneliness compared to heterosexual people. Again, often results from those experiences of discrimination and not having appropriate support in their community. And there's that overarching theme again of intersectionality and those compounding inequalities. So kind of in summary, it's important that this community health profile and the results in it are an evidence summary to start building those co-produced solutions. And it's not a fully inclusive document that will accurately map the experience of all gay men, and it should be used as a starting point only. It's important to look at decreasing stigma and discrimination associated with coming out and avoiding those heteronormative assumptions to accurately map gay men's and other monosex men's experiences with health and well-being. So I'm aware that I've just spoken and thrown a lot of facts at you over 20 minutes, so they may need some time to digest, but overall, hopefully you found it a useful kind of whistle-stop tour of some of the key health and wellbeing needs and some of those key barriers to health and wellbeing and what we can kind of do to start tackling this. So hopefully we can now kind of say, how confident do you feel after going through some of those key points? So it seems a little bit more confident, but still not at that very confident end. I would definitely say I would suggest reading that full report and taking some time to really understand and reflect, because, as I say, an hour is not enough time to fully delve into complete health and wellbeing needs, but it's useful to see that people found that it increased their confidence at least a little bit. Thank you. So now we can spend the next 10 minutes talking about what the next steps can be. So as I said, I would highly encourage everyone to go and read the Gay Men Who Have Sex with Men full community health profile report and look at potentially providing some feedback depending on your different stance. So if you work closely with the community or you identify as gay yourself, is the language that we've used throughout appropriate and relevant for the community? Is there a particular area of health that you think is important to you, or that's important to the community that we've not included? And this can be something that we can look at making sure that we include in future iterations, just so we can ensure that any activities that happen as a result of the profile consider the key priorities of the community. If you're someone that's an academic or work more in that research or that strategic level, if we've missed any key studies or any key data sets that you think would be really useful for people to be know about and shared more widely, we can also include some of the findings from those. And just any general comments and feedback would be really appreciated. So you can either email us in writing to the community's inbox, which should be put in the chat at some point soon, or you can book onto a feedback session soon that I will be setting up slots for, to have that one-on-one discussion if you'd prefer a face-to-face interaction rather than just an email. And we can also look at what can we do next following the information from this webinar. So with the profile itself, we encourage you, as I said, to read it and share it with anyone that you think is relevant. So just included a quick checklist. It's not a fully comprehensive checklist, but just some start points of what can we do as like a result of this webinar. So we would encourage you to share it with any team members or the wider organisation who would find it useful, any partner organisations or community organisations that you work with, that you know closely work with gay men and other LGBT identities. And we've included some checklists of how you can use the findings, how you can use some of this health inequality data. So have you read a section of the report that directly relates to your interest or your topic area of work? Have you maybe used this as a reference point for starting to build either new data collection or new health interventions? Have you maybe used the information that you've learned today to take along that information to relevant stakeholders to influence decision making by being that advocate for the gay community and making sure that the health inequalities are considered on different boards or different strategic meetings? And have you maybe looked at reflecting on your own practice and think about how to work towards being a more inclusive healthcare provider if that's your line of work? As I said, this is going to be a start point. We typically only have that headline data available just due to the breadth of topics covered. It's already, as I said, like an 88-page report, and that's just with that headline statistics, but it does provide a good overview of those key prevalence rates, key incidence rates, key barriers to healthcare. So now we've got a little bit of time for discussion and engagement in terms of the Menti. I'll quickly cover the upcoming opportunities that we have, and then there should still be a good 10 minutes for some Q&A. So based on what you've seen today, is there anything that you hope to see in healthcare services or community healthcare interventions, anything that would be useful to be more inclusive and supportive? Again, if you're not sure, that's fine, but just maybe potentially we can do some idea sharing. Organisation commissioning, yeah. We'll talk a little bit more about something that might link very closely to that in a second. Peer support absolutely is really important to make sure that any health interventions or any projects that we work on are kind of co-delivered and produced with the community that we want to work with, not for the community, to be able to provide that peer support and through that more culturally intelligent lens. Thank you. And just moving on, is there any other intelligence or any other resources that you think would be helpful to inform your work on addressing health inequalities effectively? So if there's something that hasn't been covered in the webinar today, or anything that isn't going to be covered by the report that we've produced, is there anything else you think would be helpful? And we can maybe look at considering implementing any ideas into kind of a long-term plan. Give it just a few more seconds. Yeah, so looking at men of sex with men specifically, there is some really interesting surveys specifically about men of sex with men, but if I can try and maybe put together some resources that people would find useful there, looking at older adults. Perfect, thank you. We'll keep those in mind. So moving on, you should be able to still access that question to put any more ideas down while we move on to the last couple of slides just in the background. But I just want to use an opportunity to quickly talk about an upcoming opportunity that we have directly following on from this, and would really encourage you, if you're from an organisation that works with the gay community, to look at it once it comes live, or if you are someone that works in healthcare, to please kind of share it out to any organisations that you know would be relevant. So we're looking to commission what we call a deep engagement partner as part of a 3-year initiative to focus on a more sustainable approach to healthcare, looking at sustainability and making sure that upskilling the community is the core principle, and linking people directly into decision makers and healthcare services that can alter and improve healthcare outcomes for gay men. We've only got 2 lots of funding available for the LGBTQ+ community, so we've decided to split it up by sexual orientation and gender identity. Although this doesn't mean that the findings will be aggregated, we will specifically still be asking that separate projects are delivered for the gay community, the lesbian community and the bisexual community as part of this project. So although it's under one umbrella, we would expect there to be that specific information for all those sub-communities. I've included a quick timeline on screen, so if anyone's interested in applying, it should go live hopefully in the next couple of weeks, and we're looking for an anticipated start of July. Now, just a quick overview of what we kind of plan to do to fill in some of those gaps that we've identified in the profile and to address some of those health inequalities. So as you've probably heard me say for a couple of the sections, there is a limited amount of data, especially at a localized level, that can help us make accurate decision making when trying to create health and wellbeing campaigns for the gay population. So one of the things we're looking at doing is specifically on focus groups. This can be led by community priorities or public health priorities to increase our primary data and our knowledge of specific health and wellbeing topics. As I said, looking into making sure there's that sustainable approach. So having community organisation voices be able to advocate for health and wellbeing needs of the gay population at different forums, like the Creating a City Without Inequality forum, for example, and also looking to co-deliver a project that actually focuses on tackling health inequalities per year, co-designed with the community. And there will also be that upskilling of the community themselves through community leadership training, health champion training, and supporting our health champions programme. So that kind of brings us to a close for today. I'll quickly just kind of wrap up before we've got some time for some questions or any discussion points that everyone wants to have for the last 10 minutes or so. So we've got 11 of these events in total. If you found any of them useful, I'd really encourage you to go to our Eventbrite page and sign up to any of the future webinars. Our bisexual webinar we held on Thursday and is already up live on the Healthy Brum YouTube channel. So you'll have a link to that access in the PowerPoint slides that we'll send around, as they hopefully later today or tomorrow. And we also are currently doing an evaluation with an academic partner. So if you have used any of the community health profiles in your report before, we would really encourage you to fill out this short survey that we have, or if you've used them in detail, to be involved in a little bit more feedback. So that brings us to a close for today. On screen, I'm just going to pop up some of those key links that we can also re-put in the chat. So if you want to reach out to us for any feedback or discussions or just conversations in general, please reach out to us at our communities team inbox. All of the profile reports, so we've got 24 currently live, can be found on the Community Health Profile homepage, and all of these recordings will be put on the Healthy Brum YouTube channel. So if you know anyone that would be interested in watching this but wasn't able to attend today, please share it widely. We also have a mailing list, so when we have any of those upcoming opportunities for funding or engagement or any other training webinars like today, please sign up to our mailing list, and that's where you'll get notified of those there. And like I said at the beginning, we have got a quick evaluation form based on the webinar today. So it would be really appreciated if you could fill out the evaluation form. Again, it's a quick 5-minute one just to let us know kind of how you found your experience today. I've also included in the PowerPoint slides that will be shared around the key references that have been included in this PowerPoint, taken directly from our community health profile, if anyone is interested in some further reading. But I think that brings us to the end of our presentation. If you want to stop sharing, Alex, and we've got 10 minutes for any discussion or conversations. We'll have a couple of minutes with the recording still on for conversation, and then we'll turn it off for the last couple of minutes in case anyone has any questions that they don't feel comfortable asking while the recording's on. So is there any questions so far? I'll have a look in the chat to see if there's anything, and on the Menti, but if anyone has any questions or would like to just put their hand up, please feel free to as well. I can't see any hands up, so I will stop the recording there.